Hello, everyone, and welcome to our module on the thalamus, hypothalamus, and limbic system. So the way I've always thought about the central nervous system is that at the top you have the cerebral cortex with the lobes like the parietal lobe, the temporal lobe, and the anterior lobe. At the bottom of the central nervous system, you have structures like the brainstem and the spinal cord. But in between the bottom and the top, you have what I call subcortical structures. These are structures that sit beneath the cerebral cortex, and they have a number of different functions that we're going to talk about in this video. So some of the important structures that sit below the cortex are the thalamus, hypothalamus, and limbic system. And we'll talk about these things in detail in this video. Also below the cortex, you find the basal ganglia, which include all these nuclei I've shown here, and I talk about those in a separate video. Sometimes we talk about central nervous system structures in terms of whether they are part of the telencephalon or the diencephalon. So let's talk about that briefly right now. The telencephalon and the diencephalon are embryologic structures that develop into the central nervous system. So structures that are part of the telencephalon include everything I've listed here. Importantly, this includes the cerebral cortex and the basal ganglia, and also some of these other structures that we'll touch upon in this video today. And then the diencephalon is the embryologic origin of the thalamus and hypothalamus. So when we're talking about these two structures, sometimes they're referred to as part of the diencephalon. Many of the structures we're going to talk about in this video today are easy to identify in cross-sections of the brain. So let's talk about that now. And we'll start by talking about what you can find on a coronal section of the brain, which is what's shown on this slide. So first of all, to orient yourself, notice that in the middle of this image, you can see white spaces. Those white spaces are the ventricles. These are the two lateral ventricles right here, and this is the third ventricle right here. Next to the two lateral ventricles near the upper portion of this image, you can find these two structures right here, which are both the caudate nuclei part of the basal ganglia. Beneath the caudate nuclei, you have these dark bluish purplish structures here, and these represent the thalamus on either side of the brain. Then what you always have is this stretch of white matter. I'm marking it on either side of the image. That's the internal capsule. That's carrying axons with motor and sensory information going back and forth to the cortex. And then down here, we have two structures which are also part of the basal ganglia. This includes the putamen and the globus pallidus. You can find one on either side of the brain. And then you can also see many of these structures in an axial section as well, which is what's shown on this slide. Once again, to orient yourself, you can identify the ventricles. This is the third ventricle right here. You only see a little piece of it. And these are the two lateral ventricles, these white spaces up near the top. Once again, you can find the caudate nucleus up near the lateral ventricles, just like what I'm circling with my pen here. Also, once again, you can see the internal capsule, but in an axial section, it actually has a bend like this. This bend is called the genu of the internal capsule. And then outside the internal capsule, once again, you can find the globus pallidus and the putamen. Those are elements of the basal ganglia. And then in an axial section, the thalamus is found right here, which I'm marking with my pen. And so you can find online lots of these coronal and axial sections of the brain. You should take a few minutes to search some of them up and get comfortable at finding the major structures fairly easily, things like the thalamus and some of the larger nuclei of the basal ganglia. Okay, so now that we've done that, let's talk about the thalamus. So the thalamus is a structure in the central nervous system that's sometimes called the gateway to the cortex. And that's because sensory information going to the cortex always travels to the thalamus first in most cases. We'll talk more about this in a second. Thalamus is a Greek word for inner chamber, and it got this name because it's an inner chamber that sits in the middle of the central nervous system on top of the brainstem. It's indicated by the red arrow in this MRI image on the slide here. It's symmetrical, like we saw in the image on the last slide. It has two halves, so you can have damage to the left or right thalamus, and that will give you different symptoms, which we'll talk about later. And then each half contains multiple nuclei, and this is one of the confusing things to learn about the thalamus. There are lots of different nuclei. They have names that aren't intuitive, and each of the nuclei carries out different functions. So some of the roles that the thalamus plays in the central nervous system are shown in this slide. First of all, it's a sensory relay to the cortex. So all sensation except for smell, which is olfaction, goes through the thalamus, and then from there it goes on to the cortex. And I talk about this in other videos when I talk about how we sense things like pain and temperature. All those sensations travel to the spinal cord and up to the thalamus where they synapse on neurons, and then they go from the thalamus all the way to the cortex. The thalamus is also a motor relay for the cortex. So motor function in the human body isn't a simple on-off switch. Motor function is fine-tuned by two important structures, the basal ganglia and the cerebellum. And both of those structures, the basal ganglia and the cerebellum, have numerous connections to the thalamus, and they use the thalamus to influence motor function in the cortex. And then finally, as we'll talk about in a little bit, the thalamus also plays a role in consciousness and sleep. And so, as I mentioned before, there are many, many thalamic nuclei. Most of them are named for their location. So there are anterior and posterior thalamic nuclei. There are also ventral and medial thalamic nuclei. 5 that I think are worth knowing at the med student level are the 5 that I've listed on the slide here. Those include the ventral posterior lateral and the ventral posterior medial, also the lateral geniculate nucleus and the medial geniculate nucleus, and finally the ventral lateral nucleus. And in case you're wondering, the word geniculate means shaped like a knee, and so the medial and lateral geniculate nuclei are named because they have a shape that looks like they're bent like a knee. So on this slide, I've made a table with the 5 important thalamic nuclei and some detail on what the function of each of these nuclei is. So let's go through them one at a time. We'll start with the ventral posterolateral nucleus of the thalamus. It receives sensory information for all regions of the body except the face on pain, temperature, touch, proprioception, and vibration. So this sensory information is coming from the spinal cord, from tracts like the spinothalamic tract and the posterior column medial lemniscus. The information in these tracts from the spinal cord is going to synapse on nuclei in the VPL region of the thalamus, and then from there, other neurons are going to transmit that information to the somatosensory cortex. The ventral posterior medial thalamic nuclei has a similar function, but for different sensations in different regions of the body. So the VPM receives sensory information on taste coming from the tongue, and also sensory information from the face. So the inputs to this portion of the thalamus are things like gustatory nerves that innervate the tongue and the trigeminal nerve, which is sensory to the face. And so once these nerve fibers synapse in the thalamus, then other neurons send that information on to the somatosensory cortex. The lateral geniculate nucleus is important for vision. It receives sensory information from cranial nerve 2, and then it relays that onto the visual cortex, which is found in the occipital lobe. The medial geniculate nucleus receives sensory information on hearing. So it comes from these regions of the brainstem that pick up sensory information on sound. These are regions with strange names like the superior olive and the inferior colliculus of the tectum. But anyway, this information goes to the medial geniculate nucleus of the thalamus, and then from the thalamus, it's relayed on to the auditory cortex. And then finally, the ventrolateral nucleus of the thalamus is important for motor function, not sensory function like all these regions. So it receives input from the basal ganglia, and it has output that goes to the motor cortex. And I talk about this nucleus a lot in the video on the basal ganglia. So there are a number of different pathologic processes that can affect the thalamus, but some of the important ones I've listed on this slide. A big one is stroke. Stroke involving the thalamus can lead to sensory loss. It will cause contralateral numbness and also tingling, which is basically just evidence of damage to the thalamus and inability of the thalamus to relay sensory information onto the cortex. There's also a pain syndrome you can get when there's damage to the thalamus from a stroke, and we'll talk about that in just a second. Multiple sclerosis is famous for affecting the thalamus. Demyelinating lesions can lead to sensory loss. Parkinson's disease involves dysfunction of basal ganglia thalamic circuits, and this leads to motor symptoms, which I talk about in other videos. And then there can also be tumors or hemorrhage into the brain that can damage the thalamus, and this can lead to various sensory and motor deficits. Strokes involving the thalamus can sometimes lead to a thalamic pain syndrome that's called Dejerine-Roussy syndrome. This is a central neuropathic pain syndrome, and by that I mean it's a pain syndrome caused by neuropathy or damage to nerves involving the thalamus. Patients who get this syndrome after a stroke will develop chronic severe burning pain. It often comes and goes in sudden episodes. These are called paroxysms, and often it's triggered by touch. And one thing that can be particularly debilitating is that patients can develop allodynia, which means ordinary painless stimuli can cause pain. So for example, someone touches the skin of the arm, and that can trigger severe pain. And the symptoms are always going to be contralateral to the side of the thalamic stroke. So a right-sided thalamic stroke is going to lead to left-sided symptoms of Dejerine-Roussy syndrome as summarized on this slide. Okay, next let's talk about the hypothalamus. And the reason it's called the hypothalamus is because it's found below the thalamus and just above the pituitary gland. If you look at this image on the slide here, this is the thalamus, this blue structure, and here's the hypothalamus right here below the thalamus. Just like the thalamus, it has many nuclei with different functions. There are 3 major regions of the hypothalamus, the anterior, middle, and posterior, and each region has medial and lateral zones, each with many nuclei. So one of the confusing things when you're a medical student is that the hypothalamus has lots of different functions, and many of them are not related, and it's hard to keep them all straight. But let's go through some of the important functions now. So you will read that the hypothalamus maintains homeostasis. So what does this mean? Well, this means a couple of different things. First of all, it's responsible for thirst and water balance. It also influences our appetite and whether or not we feel satiated. It's also important for temperature regulation. We'll talk about this in a minute, but when you get a fever, that's because the hypothalamus raises the set point for temperature in the body. And then it also plays a role in sleep-wake cycles. So all these things fall under the heading of maintaining homeostasis in the body. The hypothalamus also has a very important endocrine role. I talk about it a lot in the videos on the pituitary gland in the endocrine section, and that's because the hypothalamus controls pituitary gland hormone release. The anterior pituitary gland is called the adenohypophysis, and release of hormones from the anterior pituitary gland is controlled by the hypothalamus. And then the posterior pituitary gland is called the neurohypophysis, and the hormones released from here are synthesized in nuclei in the hypothalamus and then released from the pituitary. And then the hypothalamus also controls the autonomic nervous system, functions related to the parasympathetic and sympathetic systems, and it also plays a role in sexual urges. Okay, so just like with the thalamus, the hypothalamus has a number of different regions that have different functions. And on this table, on this slide, I've listed the important regions I think you should be familiar with as a medical student. So let's go through them one at a time. So the lateral hypothalamus contains nuclei that are important for hunger. And so if you have a lesion of the lateral hypothalamus, that will lead to anorexia in adults, or in an infant, it could lead to failure to thrive, but basically you will lose the hunger sensation and hunger drive. The ventromedial region of the hypothalamus is important for satiety. So if you have a lesion here, you won't be able to feel satisfied from food, and therefore you will eat too much, so you will develop hyperphagia, which is consuming too much food, and obesity. The anterior and posterior regions of the hypothalamus are important for heating and cooling. Cooling is regulated by the anterior hypothalamus and heating by the posterior hypothalamus. So if you have a lesion of the anterior hypothalamus, that will lead to hyperthermia, and this sometimes happens to patients who have large strokes. They damage the hypothalamus and their body temperature begins to rise. If you have a lesion of the posterior hypothalamus, you will lose the ability to thermoregulate and the temperature can go up and down. The suprachiasmatic nucleus of the hypothalamus gets its name because it's found just above the optic chiasm. It's important for maintaining our circadian rhythm, and so lesions here will lead to problems with sleep. And then the mammillary bodies are a region of the hypothalamus that are important for memory processing, and we'll talk about this later, but when there's bilateral damage to the mammillary bodies, you can get Wernicke's encephalopathy and memory loss. And then finally, the supraoptic nucleus of the hypothalamus, what you always want to remember about this area is that it is the region where antidiuretic hormone and oxytocin are synthesized. From there, they are transmitted to the posterior pituitary and released into the circulation. And so if you have a defect of the supraoptic nucleus, what you will get is a hormone deficiency syndrome, a syndrome related to loss of either ADH or oxytocin or both. Okay, let's talk about fever. So fever is a regulated increase in body temperature caused by an increase in the set point for our body temperature as determined by the anterior hypothalamus, which we just talked about in the last slide. This is the region of the hypothalamus responsible for cooling. It can modify the set point for our body temperature under certain conditions and allow our temperature to rise, and we call that a fever. Fever is usually triggered by pyrogens. These are inflammatory proteins released from places of inflammation in the body like sites of infection. So many of them are cytokines like interleukin-1 and interleukin-6 and tumor necrosis factor. They travel to the brain, and there's a region of the brain called the OVLT, which I talk about in the video on the blood-brain barrier. This region lacks a blood-brain barrier, so it can sense these inflammatory proteins, and when it senses it, it tells the anterior hypothalamus to raise the set point. The way the set point is raised is by synthesizing prostaglandin E2 in the anterior hypothalamus. And this is why drugs like nonsteroidal anti-inflammatory drugs like ibuprofen and also acetaminophen reduce fever because they block prostaglandin E2 synthesis in the hypothalamus, and that lowers the set point. And then rarely, when there's damage to the hypothalamus, patients can develop a temperature greater than 42 degrees Celsius. Normal body temperature is 37 degrees, so greater than 42 degrees is called hyperpyrexia. And this is a life-threatening situation. It can cause permanent brain damage. So when this happens, you have to do things to try and rapidly bring down the body temperature to protect the brain. So things like cooling blankets and fans. You can also give drugs like NSAIDs and acetaminophen that block prostaglandin E2 synthesis. And once again, that will tell the anterior hypothalamus to bring down the set point. Next, let's talk about leptin, which is a hormone secreted by adipocytes in fatty tissue, and it's involved in food intake and our sensation of hunger and satiety. So leptin acts directly on the arcuate nucleus of the hypothalamus, and then the arcuate nucleus influences other regions. In the lateral hypothalamus, which we already talked about is responsible for hunger, this region of the hypothalamus is inhibited by leptin. In contrast, the ventromedial hypothalamus, which is important for satiety, is stimulated by leptin. So the net effect of influencing these regions by leptin is that leptin triggers a sensation of satiety and a decrease in hunger. So things to know about leptin are, first of all, that it acts indirectly through the arcuate nucleus of the hypothalamus on these regions right here, and you should know that its net effect is to make us feel satiated and to decrease our hunger drive. When you have damage to the hypothalamus, that can lead to clinical features of what's known as a hypothalamic syndrome. This basically means diffuse damage to the hypothalamus from any cause. It could be a tumor, a stroke, it could be radiation therapy, it could be trauma. One of the main critical features of a hypothalamic syndrome is hypopituitarism, which I talk about in detail in the endocrine section. So when the pituitary gland is underactive because the hypothalamus has been damaged, this can lead to diabetes insipidus from loss of antidiuretic hormone. It can lead to growth retardation in children from loss of growth hormone. Thyroid gland can become hypoactive from loss of TRH, and you can also see adrenal insufficiency from loss of CRH. And once again, all these things I talk about in the endocrine section in detail. Also, you can get body temperature dysregulation. As we've already talked about, you can get hyperpyrexia when there's damage to the hypothalamus. And then finally, there can also be sleep disturbances, and that's because the hypothalamus plays a role in regulating circadian function and sleep. Okay, next let's talk about craniopharyngiomas, which is a very rare tumor that occurs in children. There are only a few hundred cases of this tumor a year in the United States. These tumors derive from Rathke's pouch, which is an embryologic structure. It comes from the ectoderm, and it gives rise to the anterior pituitary gland. And so sometimes Rathke's pouch, instead of just giving rise to the pituitary gland, will give rise to a tumor called a craniopharyngioma. And that tumor is going to grow upwards from where you normally find the pituitary gland. So this is first of all going to put pressure on the optic chiasm. It will cause vision loss, a specific type of vision loss called bitemporal hemianopia, which I talk about in the ophthalmology section. And then beyond this, this tumor will cause a hypothalamic syndrome in a child who has a craniopharyngioma. So the child can develop short stature from growth hormone deficiency. There can be obesity from hyperphagia. There can be diabetes insipidus from loss of antidiuretic hormone. This can present with polyuria and polydipsia. There can be fatigue for many reasons, hypothyroidism, adrenal insufficiency, and there can also be disrupted sleep. Probably the most important thing to know about this tumor is the anatomy. Because it arises from Rathke's pouch, which normally gives rise to the anterior pituitary, it's going to put pressure on the optic chiasm and also on the hypothalamus. And then the final topic for this video is the limbic system. And one thing that can be confusing when you're learning about the limbic system is that it's not one specific region of the brain. It's really a functional system made up of multiple different structures in different parts of the brain. And these structures all work together to do higher brain functions, things like emotion, long-term memory. The limbic system also mediates our sense of smell. It can modify our behavior. And then finally, it plays a role in the autonomic nervous system. So all of these sort of different and varying functions are all carried out by the limbic system, which is not one distinct brain region, but it's multiple brain regions working together. Some of the key components of the limbic system I've listed here. So they include brain structures like the cingulate gyrus, the hippocampus, the fornix, and the amygdala. These are all parts of the telencephalon. And then the mammillary bodies, which we already talked about, they are part of the hypothalamus and part of the diencephalon, but they also participate in the limbic system. One of the most important things to understand in terms of pathology related to the limbic system is Kluver-Bucy syndrome. So let's talk about that now. Kluver-Bucy syndrome occurs when there's damage to the bilateral amygdala, and the amygdala, as we just said, are part of the limbic system. The amygdala are located in the temporal lobes, and you need damage to both the left and right amygdala to develop this syndrome. When this happens, the clinical features that occur are, first of all, hyperphagia, so patients are hungry and eating all the time, and they can gain weight. Patients also develop abnormal behavior, including hyperorality, so this is a tendency to want to examine things with their mouth. Another classic feature is inappropriate sexual behavior. In particular, patients sometimes mount inanimate objects for sexual reasons. And then there can be visual agnosia. Agnosia refers to the inability to recognize visually presented objects. Patients basically won't even be able to tell that these objects exist in the world around them. And so to get Kluver-Bucy syndrome, you need damage to both the left and the right amygdala. So this usually doesn't happen from things like a stroke or a tumor. One thing that has been well described as causing this is HSV-1 encephalitis. Herpes simplex virus 1, which I talk about in the infectious disease section, can cause encephalitis, and it often involves the temporal lobes, and so it can cause damage to the bilateral amygdala, leading to this syndrome. Okay, another limbic system structure is the hippocampus. The hippocampus is found in the medial temporal lobe, and it's important for memory. If you have a lesion of the hippocampus, this usually leads to antegrade amnesia, which means the patient can't make new memories following the time of the damage. So, for example, if a patient has a lesion of the hippocampus, they will remember things that happened before the lesion developed, but after the lesion developed, they won't be able to create new memories. Now, one sort of special thing to know about the hippocampus is that it's very sensitive to hypoxic damage. So, for example, if patients have a cardiac arrest and they have global hypoxia to the brain, the hippocampus is one of the first structures that's often damaged, and that's because it's so sensitive to hypoxia. And then I'll finish this video by talking about the Wernicke-Korsakoff syndrome, which is a neurologic disorder that's incompletely understood, but it's highly associated with three things that you need to know. First of all, it's associated with thiamine deficiency. Thiamine is vitamin B1. I talk about it in detail in the biochemistry section. It's also associated with damage to the bilateral mammillary bodies, and that's why I'm talking about it here, because the mammillary bodies are part of the limbic system. And then finally, it commonly occurs in patients with alcohol use disorder, and it's strongly associated with alcoholism. Now, even though it's called the Wernicke-Korsakoff syndrome, it's really two different disorders. One is Wernicke syndrome, which is an acute encephalopathy that presents with the acute onset of confusion, and this is often reversible with thiamine. We'll talk about this in a second. Korsakoff syndrome is a chronic disorder that is usually associated with irreversible memory loss, and it usually occurs as a consequence of having already had Wernicke syndrome one or more times. And so that's why together these things are called the Wernicke-Korsakoff syndrome. So let's talk about each element of the Wernicke-Korsakoff syndrome separately, and we'll start by talking about Wernicke syndrome. So Wernicke syndrome is a classic triad of clinical features. First element of the triad is visual disturbances and nystagmus. Second element is gait ataxia, and the third element is confusion. The visual problems are usually ophthalmoplegia, which means inability to move the eyes in one or multiple directions. This is caused by weakness and paralysis of the extraocular muscles. Especially, you can see a horizontal gaze palsy where the patient can't look to one side or the other. This is often from a sixth cranial nerve palsy. There can also be drooping of the eyelid or ptosis. Exactly why all these things occur is incompletely understood. And then nystagmus is oscillating or rhythmic movement of the eyes. It's often a horizontal or gaze-evoked nystagmus, and I talk about all the different kinds of nystagmus in the videos on the cerebellum and the vestibular system. As I said earlier, Wernicke syndrome is often reversible with thiamine, and if the diagnosis is delayed or missed, this can lead to the patient going into a coma and dying. And so for this reason, anyone who presents to emergency rooms with acute onset of confusion is usually given something called a banana bag. So a banana bag is an intravenous infusion, and it contains fluids that have thiamine, folic acid, and magnesium. And the reason these three things are in the banana bag is because these are often deficient in patients with poor nutrition or patients who have been drinking lots of alcohol. And so by having thiamine in the bag, you try to treat any Wernicke syndrome that may be present. And then a super high yield thing to know about Wernicke syndrome is that it can be precipitated. In other words, it can be brought on if you give a patient glucose without thiamine who is thiamine deficient. The reason this happens is that thiamine is a cofactor for glucose metabolism. So if they're already thiamine deficient and you give them glucose, the glucose will start to use up whatever little bit of thiamine is around as it gets metabolized, and that will leave less thiamine available for regions of the brain. So this can worsen the symptoms of thiamine deficiency, and it can actually bring on Wernicke syndrome. And so once again, that's why when patients present with acute onset of confusion, or they appear to be volume depleted and malnourished, usually they're given a banana bag because you don't want to give those patients glucose without making sure you replace any thiamine that might be missing in the first place. And then Korsakoff syndrome is usually a permanent syndrome, as I mentioned before. It includes elements of amnesia. Recent memory is affected more than remote memory, so patients may not remember things that just happened, but they will remember things in their remote past. In particular, patients have trouble coming up with new memories. A classic feature of Korsakoff syndrome is confabulation, so patients can't remember things, so they make things up. So when you ask them where they were this morning, they don't remember, but instead of saying, "I don't remember," they make up a story of something that didn't happen. Korsakoff syndrome is also famous for the patient showing a lack of interest or concern. So even though they may not remember things and they may be confabulating, They actually have sort of a blasé or disinterested demeanor. And then finally, there can be various personality changes that are all part of Korsakoff syndrome. And once again, this is usually a permanent consequence of thiamine deficiency that first led to Wernicke's encephalopathy, and then after one or multiple bouts of Wernicke's, that can lead to the permanent Korsakoff syndrome. In this image on the slide here is an MRI. The arrows are pointing at the bilateral mammillary bodies. There's often damage to the mammillary bodies identified in MRI in patients who have Wernicke and Korsakoff syndrome, and that's why I'm showing you this image on this slide. And that concludes our module on the thalamus, hypothalamus, and limbic system.